Australian psychiatrist named John Cade published a paper that almost nobody read. He had been working in a psychiatric hospital testing patients with severe mania, people who had been hospitalized for years, sometimes decades, cycling through episodes of frenzied energy and deep collapse that nobody could explain and nobody could reliably treat. Cade had a theory. He thought that uric acid might be involved. He wanted to dissolve it in something and inject it into a guinea pig. The most soluble form he could find was lithium urate. The guinea pig got unusually calm. Cade followed that observation. He started giving lithium carbonate to his most severely ill patients, 10 of them, all with intractable mania that had resisted every other intervention. He reported remarkable results. One patient who had been continuously hospitalized for 5 years became so stable he was able to return home and go back to work. It should have changed psychiatry immediately, but it didn't. The American medical establishment largely ignored the paper. Lithium was unpatentable. No pharmaceutical company had a financial reason to push it. And in the United States, it had been recently removed from the market as a salt substitute after several deaths from toxicity, leaving a bad reputation it would take decades to overcome. It wasn't until the 1970s, 21 years later, that the FDA approved lithium for the treatment of mania in the United States. 21 years, during which time hundreds of thousands of people cycled through manic and depressive episodes with no effective treatment because a discovery got lost in the gap between evidence and action. I want you to hold that for a moment. Because mood disorders are among the most common, most debilitating, and most misunderstood conditions your future clients will bring through your door. Major depression is the leading cause of disability worldwide. Bipolar disorder is misdiagnosed in up to 70% of cases because the correct diagnosis is made, and the average delay between first symptoms and accurate diagnosis is about 10 years. 10 years. Your clients will arrive carrying all that history. Today, we're going to make sure you know how to recognize what they're carrying and how to distinguish one mood disorder from another with precision that both your exam and your clinical practice will demand. Hey folks, welcome to the Licensure Lifeline, the podcast that helps you build the clinical knowledge and confidence to pass your exam and grow as a clinician. I'm Matt Lawson, and today we're going to do something we haven't done yet in this season. I mean, this is only the second episode, but we're going to go deep on diagnoses, specifically mood disorders, MDD, bipolar 1, bipolar 2, and persistent depressive disorder, the DSM-5 criteria, the clinical presentations, and most importantly, the differential diagnosis distinctions that show up on every licensure exam. Because this is the thing about mood disorder questions on the exam. They're not really testing whether you memorize the criteria. They're testing whether you can tell the difference between conditions that look similar on the surface but require completely different clinical responses. That's the skill we're building today, or foundationally establishing today. We're going to have the exam questions, and don't forget there is a newsletter that goes along with this that will provide a deeper dive. You can access the newsletter through the website, www.licensurelifeline.com. The newsletter is free. It just is an extra piece that I'm giving people that I'm hoping will help out with your studying. Also, I want to thank everybody that has joined the Circle group so far. This is so exciting. I mean, we are building a community from the ground up. Again, you can check out the Circle community again through the website. You can get the link there. You get 2 weeks free just to take a look, to see what it's about. If you decide to move forward with it, excellent. We are building something here that I'm hoping is going to be pretty unique for the studying experience for these exams, and then afterwards. Also, we have launched the YouTube channel that is up and going. YouTube channel is going to be pretty unique. You're going to be able to access all the podcasts through the YouTube channel. Plus, I'm going to lean into some videos and things like that around some side projects, one of which I'm calling Seventh Wave, and it's kind of a tech-forward, tech and mental health piece that, it's just personal interest of mine that I'll be getting there as well. All right, so let's get on to the news. A couple of stories for you guys this week. First, the FDA approved Bysanti misoperidone. Try saying that really quick 5 times. This is for acute manic and mixed episodes in bipolar 1 disorder came available early 2026. It's a new chemical entity in the atypical antipsychotic class, drawing on more than 100,000 patient years of real-world safety data from related compounds. So why does this matter? As a pre-licensed therapist, we're not prescribing, but you need to team up with a psychiatrist or a prescribing clinician. Because medication is part of the clinical picture a lot of the times with the people that we work. We need to understand the medicines behind this stuff. We need to be kept abreast of new treatments. I see so many people that come through the practice and they're considered, unable to treat, or they've tried everything on the market and it just hasn't worked for them. So when new things like this come out, we need to be able to talk about it. We need to be able to point them in the right direction to really get a deeper understanding of how it may help them. Okay, on to the next story. 70% of people with bipolar disorder are misdiagnosed at least once. According to research, and depressive episodes, which are typically longer than manic episodes, can last months, during which individuals may feel intense sadness, hopelessness, along with changes in sleep or appetite and thoughts of death or suicide. That 70% misdiagnosis rate is a clinical number I want you to remember from today's episode, not because it makes the diagnostic system look broken, but because it explains why differential diagnosis between major depression and bipolar disorder is one of the most consequential clinical skills you can develop. The first presentation of bipolar disorder is almost always depressive episode, which means the clients are actually bipolar frequently and get treated for unipolar depression first, sometimes for years. And again, something I see all the time. People have bipolar disorder and they're only being treated as if they have depression. So again, this is one of those places where it's really, really nice to have a team of people on your side, getting other observations from other clinicians, primary care docs, other people that are working with this person, and allows you to talk to everybody. You can talk about, what you're seeing and see these different angles that you get of the same individual. When people are having their manic episodes, they tend to report that they're feeling great. They feel fine. Again, like we tend not to treat people that feel great and fine, and they tend not to get treatment. You tend to only see them when they are coming in on the depressed side of this. So something to keep in mind. All right, let's start with the architecture. The DSM-5 separates mood disorders into 2 major categories: depressive disorders and bipolar and related disorders. Today, we're covering 4 conditions, 2 from each category. From the depressive disorders, we're going to look at major depressive disorder and persistent depressive disorder. From bipolar and related disorder, we're going to look at bipolar 1 and bipolar 2. The organizing principle underneath all of them is the episode. And this is what trips up so many people, trying to keep straight, like how many days, how many months symptoms need to be present in order to make a diagnosis. So I'm hoping, again, we can give you some tools here, some foundational pieces that are really going to help you with this. So you want to be looking for how long and what kind of symptoms and how they are arranged across time. That's the clinical and diagnostic lens that makes everything else make sense. First, we're going to get into major depressive disorder, MDD. MDD requires at least 1 major depressive episode, and a major depressive episode is a specific clinical construct with specific criteria, not just feeling sad. Everyone feels sad, right? Like that's a part of being human. This is a depressive episode is something unique. The DSM-5 requires 5 or more symptoms from all of the 9 present during the same 2-week period. 2-week period, I'm repeating that. And at least one of the 5 must be either depressed mood or loss of interest or pleasure. The 9 symptoms, and this list is worth knowing cold, you're just going to have to know it. So depressed mood most of the day, nearly every day. Markedly diminished interest or pleasure in almost all activities. Significant weight change, gain or loss, so appetite disturbance. Sleep disturbance, insomnia or hypersomnia. Psychomotor agitation or retardation, observable by others, not just self-reported. Fatigue or loss of energy, feelings of worthlessness or excess and inappropriate guilt, diminished ability to think or concentrate, or indecisiveness, recurrent thoughts of death, suicidal ideation, or suicide attempt. The mnemonic most people use is SIG-E CAPS. So SIG space E space CAPS. Sleep, interest, guilt, energy, concentration, appetite, psychomotor, suicidality. You've likely seen this somewhere at some point. I highly recommend you maybe making up a little mnemonic for yourself. It helps if you can somehow make something that's unique to you. Use something that's fun for you, like a favorite book or things like that you can kind of create the mnemonic around. It's just going to help you memorize it that much easier. But 2 things worth knowing beyond the list itself. First, the symptoms must cause clinically significant distress or impairment. That's the difference between a depressed episode and just sadness, right? Someone who checks 5 boxes but is fully functional does not meet the criteria. The functional impairment criteria matters. Second, the symptoms must not be better explained by substance use, another medical condition, or another mental disorder. So ruling out isn't just clinical good practice, right? It's part of a diagnostic criteria. So you need to ask these questions. If you're going through this and you get around to a place where somebody's talking about how depressed they are all the time, but they're also drinking every night, that's something that you have to consider. That might completely mess with the diagnosis of this. Drinking is going to cause depression. Alcohol is a depressant. People that drink alcohol on a regular basis are going to be depressed. That's just the way it goes, right? All right, next up, persistent depressive disorder. That's PDD, also known as dysthymia. Persistent depressive disorder is the DSM-5 name for what used to be called dysthymia. And the most important thing to understand about it is that it is defined by duration, not severity. PDD requires depressed mood for most of the day, more days than not, for at least 2 years in adults, 1 year in children and adolescents, plus at least 2 of 6 additional symptoms: poor appetite or overeating, insomnia or hypersomnia, low energy, fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. So the clinical reality of PDD, people who have it often don't recognize it as depression. They have felt this way for so long, sometimes since childhood, that they experience it as their personality, which is so sad. That they've been carrying this for such a long time, and they just accept it as like, this is just the way of the world. This is just how I am. And it doesn't have to be that way. I've just always been a sad person. Like that's some of the stuff you'll hear, right? Is one of the most common presentation of undiagnosed PDD. And people will say that. They'll just come in and say, yeah, this is just who I am. I've just always been sad like this. So, it's something to definitely take a look out for. The exam concept is worth knowing here. Double depression. If someone meets criteria for both PDD and MDD, meaning a major depressive episode develops on top of an already existing persistent depressive episode. So that's considered double depression. So a little bonus concept here. And it's a specific term. It's not really testable, so you're not going to see double depression on the test. But it's just something to keep in mind. You actually can have somebody come in that has PDD and MDD occurring together. So, okay. Now we're going to get into the bipolar disorders. So we're going to start off with bipolar 1. And again, these are all framed within time limits and different severity patterns and things like that. So it's kind of a pain in the butt, but you need to figure out some way to keep this stuff straight, because it matters, and it will just give you points on the test if you can figure out some system to remember. So bipolar 1 requires at least one manic episode. That's the defining criteria, not a depressive episode, a manic episode. Though most people with bipolar 1 do experience depressive episodes, they're not required for the diagnosis. A manic episode is a distinct period of abnormality, abnormally in persistent, elevated, expansive, or irritable mood, and abnormally in persistent, increased goal-directed activities or energy, lasting at least 7 days or any duration of hospitalization is necessary during this time period. So we actually had somebody with bipolar 2 come and speak to our class while I was in grad school. And it was a fascinating story. This individual would stay up for nights at a time. He was an entrepreneur. He made and lost fortunes. I'm talking millions of dollars over time, where he would gain and lose. He told a story of how one time in a manic episode, he had a custom Chris Craft boat made on the other side of the country. I believe he was like in Chicago or the East Coast at this time, and he had something made, I think it was in Portland, during a manic episode, and he forgot about it. And something like a year later, the company that made it called him up and was like, "Hey, you ever going to come pick up this boat?" That he completely forgot about. And, next thing you know is he's driving across country to pick up a boat. So that's, what we're talking about when we talk about manic episodes for individuals. So these are some of the criteria that need to be present during these manic episodes. So 3 or more of the following must be present. So inflated self-esteem or grandiosity, decreased need for sleep, not insomnia, but just a decreased need. The person feels rested after 3 hours, let's say, more talkative than usual or pressure to keep talking, flight of idea or subjective experience that thoughts are racing, distractibility, increase in goal-directed activities or psychomotor agitation, excessive involvement in activities with high potential for painful consequences, spending sprees, sexual indiscretions, foolish investments. And here's the clinical distinction that matters most. Manic episodes caused marked impairment in social or occupational function, or require hospitalization, or involve psychotic features. This is what distinguishes mania from hypomania, which we'll get into here in a moment. So bipolar 2 is often misunderstood, including by clinicians, as a milder version of bipolar 1. Bipolar 2 requires at least one hypomanic episode and at least one major depressive episode with no history of a full manic episode. A hypomanic episode has the same symptom profile as a manic episode, but lasts at least 4 consecutive days rather than 7, and is not severe enough to cause marked impairment or require hospitalization. Here's the clinical complexity. Hypomanic episodes often feel good. The person has more energy, more confidence, needs less sleep, is more productive. They may not present it as a problem. They may present it as, this is when I'm at my best. The clinical challenge is recognizing that what feels like wellness or even optimal functioning maybe a hypomanic episode that's part of a bipolar pattern, and treating that person's depressive episodes with antidepressants alone without mood stabilization can trigger a hypomanic episode or rapid cycling. This is why 70% of people are misdiagnosed, and that rate, exists. First presentation is depression. The hypomanic episodes are sometimes not recognized as episodes at all. They're just, people coming out of their depressed state. And years may pass before a full picture really emerges. That's why this is so complex. It is like when people again, like as I said earlier, oftentimes get diagnosed with just having depression, and because they feel so good when they come out of their depressed episodes with this hypomania, that, it's just like, oh, you're returning to baseline. But it's not. And, that's why, getting the person's story, really matters. Their story over time really matters, is it's going to give us that much more just understanding of their world. So every mood disorder question on the license exam can be answered by asking two questions in sequence. Question 1, has there ever been a manic episode? If yes, you're in bipolar 1 territory. Full stop. It doesn't matter what else is present or what else is present. One manic episode in a lifetime means the diagnosis is bipolar 1. If no, move to question 2. So we're kind of creating a little bit of an answer tree here. Did you get that? So if you answer yes to has there ever been a manic episode, you're in bipolar 1 territory. All right. Question number 2, has there ever been a hypomanic episode? If yes, and there's also a history of major depression, bipolar 2. If no, you're in depressive disorder territory. Then the question becomes MDD versus PDD, which depends on duration and whether there have been discrete major depressive episodes. I don't know if you guys are familiar with mind maps, but I highly recommend you get familiar with mind maps. This was the way that I studied in grad school. I used to make mind maps of all of this stuff. And mind maps are really fun. People call them tree diagrams, but they give you order. They give you visual order. I'm a visual guy. I love art. That is, I love sunsets. I visualize things. I make pictures in my head. I realized, like, when I was in grade school, that when math problems would pop up, or when I would take a math test, I would see pictures of things like being added together in order to get the solution. And mind mapping this stuff really helps out. Being able to ask yourself questions like this and then see on the mind map what node it goes to next, and then what node it goes to after that, is really going to help you answer some of these questions, especially if you're a visual learner. So those are the two questions, the entire differential diagnosis tree for today's episode. The exam version of this might be a vignette in where somebody's described their symptom history, and your job is going to be to identify whether any episode in that history, including something that might be described positively, like a period when they needed less sleep and felt incredibly productive, constitutes a manic or hypomanic episode. If it does, you're bipolar. Which one depends on the severity and the duration. Here's what mood disorders look like when they walk into your office. Major depression doesn't always look like sadness. Sometimes it looks like irritability, particularly in adolescents and men, who may present with frustration and anger rather than tearfulness. Sometimes, that's before I continue, that's so important to remember. Guys, adolescents, they present with major depression with irritability. And, a lot of the times you'll get this, like, well, people say that I'm grumpy all the time. And, it is, or you'll be doing couples counseling, and one of the significant others will say like how, the guy is just a grump, and really like they feel like I irritate them all the time. That is something to keep in mind. Sometimes it looks like physical complaints, chronic pain, fatigue, headaches, with the emotional component minimized or unrecognized. Sometimes it looks like emptiness rather than sadness, or inability to feel anything rather than feeling something overwhelmingly bad. Bipolar disorder in the depressive phase looks like depression. That's why it gets missed. Your client in a bipolar depressive episode meets criteria for MDD. The only way to know it's bipolar is to have a complete history, and specifically to ask about the other side. Has there been periods when you felt the opposite of this? Periods of unusual energy, decreased need for sleep, thoughts racing, feeling like you could accomplish anything. That question is one of the most important questions in the mood disorder assessment. It won't be asked if you don't know to ask it, right? You need to know this stuff in order to ask the right questions. Persistent depressive disorder looks like a personality. The person doesn't describe themselves as depressed. They describe themselves as pessimistic, low energy, never really happy. The depression has always just been there as long as they can remember. The clinical task is gently helping someone see that what they've normalized as who they think they are actually can be something that is treatable. That's one of the more amazing things with this is somebody will think that they just like this is just the person they are, but it's actually treatable and you can help them. All right, how about we get into some multiple choice question? First, a client presents to therapy reporting 2 weeks of low mood, loss of interest in activities she's previously enjoyed, significant weight gain, hypersomnia, fatigue, and difficulty concentrating. She denies suicidal ideation. She reports no previous episodes of elevated mood or increased energy. According to the DSM-5, the most appropriate diagnosis is A, persistent depressive disorder, B, bipolar 2 disorder, C, major depressive disorder, or D, cyclothymic disorder. Answer is going to be C. This is major depressive disorder, MDD. The client meets criteria for major depressive episodes, 5 or more symptoms from the 9 items listed for at least 2 weeks, with at least 1 being depressed mood or loss of interest. The absence of any history of elevated mood rules out a bipolar disorder. The 2-week duration rules out a diagnosis requiring longer duration. MDD is the correct diagnosis here. Question number 2. A client reports that he has struggled with low mood, low energy, poor concentration, and low self-esteem for as long as he can remember. He describes himself as just a pessimist and says he has never had a period of feeling well for more than a few weeks at a time. He's 34 years old and has never been in treatment. No manic or hypomanic episodes are reported. The most appropriate diagnosis here is A, major depressive disorder, B, persistent depressive disorder, C, bipolar 2 disorder, or D, cyclothymic disorder. The answers are going to be B. The key feature here are duration and continuity. The client has had depressed mood most of the time for what appears to be years, likely since childhood or adolescence, without extended periods of wellness. He describes it as his personality rather than as a mood episode. This chronic, low-grade, persistent pattern is the clinical signature of PDD. Question number 3. A 28-year-old client presents with a 3-month history of depression following what she describes as the most amazing month of her life, during which she slept only 4 hours a night and felt fully rested, started 3 new business ventures simultaneously, talked constantly, and felt that she could accomplish anything. She was not hospitalized during that period and continued to work. Which of the following DSM-5 diagnoses is most consistent with this presentation? Is it A, bipolar 1 disorder, B, major depressive disorder with hypomanic features, C, bipolar 2 disorder, D, cyclothemic disorder? Answer is going to be C. The amazing month is a hypomanic episode. Decreased need for sleep, increased goal-directed activity, talkativeness, grandiosity lasting at least 4 days, followed by a major depressed episode. The key distinction from bipolar 1 is that the elevated period did not result in hospitalization and did not cause marked functional impairment. She continued to work. That's the hypomania piece, not mania. Bipolar 2 equals at least one hypomanic episode plus at least one major depressive episode with no history of full mania. Question number 4. A client with a 5-year history of low-grade depression develops a new episode, significantly worsened depressed mood. Neurovegetative symptoms, a passive suicidal ideation lasting 3 weeks. The most accurate clinical description of this presentation is A, bipolar 2 disorder with depressive episode, B, major depressive disorder, severe, C, double depression, a major depressive episode superimposed on a persistent depressive episode, or D, adjustment disorder with depressed mood. I know this is a lot, right? We didn't even talk about these qualifiers like severe, but the answer is going to be C, double depression. Double depression describes the clinical phenomenon in which a major depressive disorder develops on top of a pre-existing persistent developed depressive disorder. The client has a 5-year baseline of low-grade depression, PDD, and now a 3-week period, significantly worsened symptoms, meeting criteria for a major depressive episode. Just a quick note about the test, especially like the NCE. You're going to see some questions around that are going to have like time periods and things like that. It's not punishing. Let me just put it that way. They pepper these questions in and out. It's not going to be a ton of questions on where you're going to have to know specific times and all these other pieces. They're actually pretty kind about that. I want to say, it is not to say that we don't need to know this stuff, not to say that's, not important to know. But if I can alleviate some anxiety around how much of you that you need to keep in your head around time and things like that, let go because they are not punishing when it comes to knowing, because there's so many different things, so many different diagnoses that are dependent on specific time periods, 3 weeks, a month, a year, whatever. I want to say that they focus more on the big ones, like MDD and bipolar. But it's not punishing. All right. Question number 5. A therapist is conducting an initial assessment with a client who presents with a current depressive episode. In taking a thorough mood history, the therapist specifically asks, have there ever been periods, even periods that felt positive, when you needed significantly less sleep than usual, had unusually high energy, or felt like you'd accomplished more than normal? This question is best understood as A, an unnecessary leading question that risks suggesting symptoms to the client, B, a screening question designed to identify possible hypomanic or manic episodes that would change the diagnosis and treatment approach, C, a question about anxiety that is not relevant to the mood disorder assessment, or D, a technique from motivational interviewing designed to identify ambivalence about treatment. The answer is going to be B. This is one of the most important questions in mood disorder assessment, and one that most is often commonly just skipped because the first presentation of bipolar disorder is almost always depression. Asking about elevated mood, periods of is essential to differential diagnosis. The question is specifically designed to surface hypomanic or manic episodes that the client may not have flagged as problematic because they often felt good. Identifying a hypomanic history changes the diagnosis from MDD to bipolar 2 and fundamentally changes the treatment approach, including the risk of using antidepressants without mood stabilization. Okay, 3 things before you go on with the rest of your life from this episode. 1, know your episode criteria cold. Better yet, come up with some type of system that helps you remember this stuff cold. So duration, symptom count, and the functional impairment thresholds are what distinguishes one mood disorder diagnosis from another. 2 weeks for MDD, 7 days for mania, 4 days for hypomania, 2 years for PDD. Those numbers will appear on your exam for the most part. These are the big ones. So like I said, we want to keep the big ones in mind. 2, the hospitalization criteria separates bipolar 1 from bipolar 2 more cleanly than any other signal feature. Manic episodes require hospitalization or cause marked impairment. Hypomanic episodes don't. That's the line. People do not show up in the hospital for hypomanic episodes. So, what you'll see with manic episodes are people might do things to themselves that could endanger themselves. Racing their car really, really fast. Excessive drinking that leads to public intoxication charges and things like that. So with manic episodes, you're going to see hospitalizations, something to keep in mind and ask about. 3, always ask about the other side. In any depressive presentation, a thorough mood history includes asking about periods of elevated mood, decreased need for sleep, and increased energy, even when those periods felt positive. That question is not optional. It's how bipolar disorder gets correctly identified instead of misdiagnosed for decades. Okay, so the newsletter, it's going to go deeper into all of this stuff. Full specifier guidelines, things like that. Some of the clinical nuances, and I do have a vignette in that as well that you can go through that's going to help out. Next week, we will continue to build out some diagnostic domains. There's a lot of ground to cover in the DSM. I'm actually probably going to create something separate from the podcast just to help people study for the DSM. I think it's worth it. There's just so much information to cover here that I feel like there needs to be almost an extra tool. So don't forget, check out licensurelifeline.com. That's the website. Also, you can reach me at Licensure Lifeline, one word, at gmail.com. That's the best place to ask me questions, to leave comments on the show, things like that. I always love hearing from people, so please reach out when you can. And until next time, everyone, keep learning. Take care.